So thank you so much, Ken, Alba, and Amy, for sharing your expertise and your thoughts with us. You've given us a lot of information to digest and think about. I'm sure there are many questions. Actually, there are many questions already down here, and I've been jotting my own as you've been speaking too. So it sounds like one of the major themes in the questions is how we find providers that understand all of this. Is there any kind of database for physical therapists that are, I guess, what you would call literate in ME/CFS? And, you know, or is there any other way we could go about finding these providers who understand or who are learning about this research?
Well, I guess I'll take that point. No, there's not a database of OTPT literate in PEM, and that needs to be done. There needs to be training, certification. There needs to be a way to network, and there is a Facebook group of us that are providers that Sally Reditsky and Melinda Maxwell and I are involved with, and we encourage providers to join our group, and it's physical therapists, occupational therapists, resources for treating ME/CFS, and we're a Facebook group, but that's not for how patients can find specific providers in their area. So I guess that is a great need. And I think the first part is by people being able to take some tools into providers and say, this is what I'm struggling with. Can you help me? Are you aware of PEM? Are you aware of some of the guidelines? Are you willing to do the work? Because maybe the best therapist and the best provider is not the one with 30 years experience. It's actually the new ones that have a lot of interest and are passionate about learning. And you can always train somebody to get the skills. It's just that, you know, the people that have probably been studying it the longest, they probably, unfortunately, have been using the traditional models. And I think we just need to kind of reinvent the wheel and try to figure out how to get more people on board with PEM and understanding, and then we'll be in really good shape. But until then, unfortunately, I'm sorry, no.
Yeah, thank you so much. Alba and Ken, did you have any comments on that question?
I'm actively working with Amy to try to train some people because it's not, it's just not widespread knowledge at this point.
Yeah, thank you. I did just want to give a shout out to the Mass ME/CFS organization foundation. They do have a little link on their website that you can click on. I'll share it in the chat in just a bit. If you are a resident of Massachusetts or New England, you can contact them for, you know, provider specific information. If you're looking for a physical therapist who understands, and we're still working on building that database. If you live in another part of the country, or if you're in another country other than US, I would suggest just checking out your local support groups or your local organizations for ME/CFS and see what they have to say, because that seems to be where all this information and all these advocates are, right?
And also there's a really great group in the UK, Physios for ME. And so they do have a great resource network that, at least to get information for providers that are willing to work with the information. Mm-hmm. Look at Physios for ME page, because they do have some work to some worksheets and everything.
Yeah, great, thanks. And then I guess this kind of piggybacks on that previous question. Is there any way, are there any suggestions any of you have for responding to a provider that is recommending things like graded exercise therapy versus pacing, or even just, you know, self-advocacy in general, you know, because there seems to be a lot of gaslighting by providers towards patients with ME/CFS?
I can take a shot at that, having been through it. I think the first thing that one needs to do is to find a provider, and in finding a provider, I think the first step is an interview. What's important to you needs to be articulated to the provider, and ask him or her for his or her response to what is considered important to you. If the provider can't be sympathetic or supportive of the things that are important to you, then you need to keep on your search. Your search has not been successful at that point, and so therefore you need to search forward. There has to be a good fit between the provider and the patient. There has to be a rapport between them, and if that is not there, that relationship will not work. I think one of the concerns that have been raised in the medical community is that I'll go out on a limb and say the predominant healthcare model provides 15 minutes allocated to the provider per patient, and certainly for ME/CFS patients, that is an insufficient amount of time. So one of the things that needs to be looked for is a provider that is willing to go beyond 15 minutes per session to be with you in order for you to make progress. And if that provider isn't willing to, then again, you just need to go on. It's very difficult. It may take years for you to find a provider.
Mm-hmm.
And I just want to share a little bit about the perspective of a provider in seeing this patients. It's complex. I mean, never as complex for us as it is to be the actual patient, right? The suffering, it's incredible, but for physicians, it's not easy. I have a group of physiatrists that a lot of them have decided not to take care of the clinic anymore, or see patients in the clinic anymore because it's so tough. We want to sign up to do medicine to make people get better, and a lot of medications, like patients are very sensitive to medications. Dosing has to be done very meticulously. Constant titration, frequent visits. It's not simple as a provider, but I think that, for example, telling somebody to put earplugs because sound sensitivity was horrible was one of the biggest interventions that I've done on a patient. And there's value to that. So I think that it's important as a physician to just allow a safe space for patients to tell you what they're experiencing and what their body's telling them. So I think if you find a physician that allows you to feel safe enough to express what your body's telling you, I think that goes a long way for sure.
And I have one more point. Because there are so many comorbid conditions that people are experiencing, sometimes finding a therapist who has experience with PACTs or Ehlers-Danlos can also widen the search a little bit with, by going to a Facebook group or looking for somebody that has had a good experience with a therapist. By getting a recommendation through other groups is also a way to find willing therapists. And unfortunately, this is what's so brutal, is most of them are private pay. So that's a whole other layer of the onion that it's costly.
Yeah, it's unfortunate. I wish all providers could be like the three of you. I'm sitting here just, we only had more of you guys in the field. Thank you so much for those answers. Those are great. It is now past 5:15. So if anyone needs to sign off, we completely understand. And this is going to be recorded and posted on the Mass ME/CFS YouTube channel as soon as we can, as well as the slides will also be posted on our at massmecfs.org website. I just wanted to ask a couple more questions, if that's okay with you all. There were a couple of questions about the equivalent for the device for measuring cognitive exertion. I know you talked a lot about medical devices and you know, your heart rate monitors and stuff like that, but many patients with ME/CFS have this cognitive fatigue too. Is there anything out there that helps actually measure that?
No.
Other than maybe, I mean, I guess it's not a standardized measure, but doing some checklists on how people are handling some of the ADLs and multiple steps. You can do some in the IADL, more executive functioning levels, looking at how they can work through a problem or do a task from start to finish. So OTs also are well versed in activity analysis. So watching a person actually perform a task or work through a task is a way to maybe look at at what level they start losing their focus. Yeah.
I wanted to give a shout out to the speech language pathologists, which are the one therapy team that we haven't talked about much. And we definitely, in our clinic, we have speech language pathologists that work in cognitive therapy. Again, you have to be really mindful of the PEM on those patients, but they can be helpful in kind of giving tasks and seeing the response to those tasks and helping you find what is that threshold, you know, if it's 1 hour, 2 hours, and then taking a break. A lot of people find that helpful. Like Dr. Friedman was commenting, like breaking up the sessions of computer work, for example, if that's what they do for their job, into smaller pieces and having breaks in between. So sometimes the speech language pathologists can be helpful in finding compensatory strategies as well to compensate for memory issues, for sequencing issues that they may have. So yeah, that's another group of therapists.
The piece, though, I want to point out is often with people with ME and long COVID with PEM, these are not necessarily permanent. I mean, there are permanent brain damage issues, or, you know, cognitive impairments, but it is most often a temporary situation. And by actually reducing PEM and reducing symptoms and doing different strategies and compensations, it provides more cognitive bandwidth for harder tasks or things that are going to be more meaningful. And you know, the focus that somebody wants to be doing a very important task at a certain point in the day, by teaching them compensation strategies earlier to be able to manage that cognitive fog piece. So some of it can be for people that have had long time ME, but it's not necessarily treated as like somebody that has had a stroke. And there is, you know, there's definitely some neurological impairments from the cognitive levels.
Yeah, that makes a lot of sense. Thank you so much. And then, Amy, there are a couple of questions for you about how do you move towards finding the anaerobic threshold? There are a couple comments, just people wanting more information on that.
Go to Work Well and they have a lot of information on their website, workwell.com, I believe. It's a group of exercise physiologists and PT. So that information is at their website, but it's also looking at kind of where, if you don't have the resources to go and really get the certain tests done, by finding out and doing more journaling on where you feel you are best able to be productive and where your work is managed before you start feeling the effects of PEM. So it's kind of like a self checklist, and staying under that window and start monitoring your pacing, because as soon as you feel like, okay, it's been 10 minutes, I've been upright for 10 minutes, I can feel my brain fog setting in and I'm getting maybe nauseous, I've got sore limbs, that is beyond. You need to have stopped at 8 minutes. And so the next time you have an activity, set the alarm, literally like turn on your alarm that at 8 minutes, you need to do a self-check. So just doing a lot of self-check strategies is a way of managing without having the clinical resources to really pinpoint when it is that you're actually, your body is physically changing into lactic acid results. So doing, just doing a lot of self-monitoring is kind of the low-tech way to do it. Also using some heart rate, just buying, a Fitbit and watching how your body is responding to certain activities.
This is actually a personal question. Do you know if insurance companies cover like Fitbits now, or is that something that we still have to go out and buy on our own if there's a certain like diagnosis along with it?
I haven't heard of anybody getting it paid for, but I'm not sure.
Popped in my mind because I was like, I want one for myself, but if patients are if that would greatly help them, it would make sense. But a lot of things need.
Can I just add a little bit to that from the physiological, point of view? Going into your anaerobic threshold obviously has to do with oxygen consumption, and your body monitors oxygen consumption. And one of the things that happens when your oxygen consumption gets lower, obviously your blood oxygen becomes lower, and the body responds by increasing heart rate. In other words, trying to get more oxygen to the tissue by increasing the flow of blood, because in the blood is where the oxygen is that gets into the tissue. So by monitoring heart rate or a change in heart rate, particularly an increase in heart rate, you get an idea as to when you are consuming more oxygen. And yes, it's true, a Fitbit would be ideal, but I think a Fitbit is kind of pricey. You can also buy something called a pulse oximeter, which you put on your finger. It has maybe 1 or 2 small batteries in it, and you clip it on your finger. It will tell you your oxygen concentration, but they also tell you your heart rate. So that, and I think they're about $30, maybe $40 last time I looked. So for $30 or $40, you can buy a pulse oximeter and focus on the heart rate monitoring aspect of it as you do something, and try and correlate the increase in heart rate that you see with the onset of the anaerobic threshold. Just try to stay below a certain heart rate to maintain your ability to continue work.
Great. Thank you. I know we hear about pulse oximeters a lot with talking about COVID and acute phase of COVID. There were a couple of questions for you, Ken, about, whether or not, or how to distinguish maybe ME, CFS onset after a concussion or other physical trauma with no known pathogen exposure, and just other maybe illnesses such as like breast plant illness causing ME, CFS, and then, comments coming from COVID long haulers on that connection with ME, CFS. Do you have any more comments in relation to what you said about PAPIS, finding the specific causes, or whether or not that's helpful, or do we just kind of accept that we're in this umbrella of ME, CFS?
Well, at this point, the actual cause or causes are unknown. There are obviously some candidates that are higher ranked than others.
Mm-hmm.
Most likely, I think immunology is involved. I think that for both viral and bacterial infections, there is talk about the immune system becoming overworked and therefore no longer being able to provide the surveillance or suppression of the viral illnesses that once were. I think that for both, and for the majority of ME/CFS cases and for long haul COVID, the virus remains in tissues. For most of us, it remains contained within the tissue, but under certain circumstances, when the immune system is no longer adequately active, then those viruses can emerge from the tissues and start circulating throughout the body. And then you have an infection again. And I think for a lot of ME/CFS patients, their condition can be correlated with the viral load that's found in the blood. They feel better when the viral load is low in the blood. When they feel worse and they go to their physician and viral titers are assessed, they find out that yes, their viral titers are back up, and they try and knock them back down with antivirals again. I think that the example that has existed is probably chickenpox and shingles. At one time, it was thought that chickenpox was a childhood disease and you just get over it and it's gone. And it turns out that no, the virus does remain and can express itself later in life when your immune system starts to decline, such as in people like me. And you can get a reemergence of the chickenpox virus, and it takes the form of shingles going along essentially the pathway of nerves and expressing itself on the surface of the body, being particularly painful. And there are other examples like that. So I think we need to recognize that it is a common, if you pardon my language, physiological phenomenon at this point. And once we recognize that and attempt to deal with it, we will have better tools for treating a lot of other people.
Okay, great. So we just have one last question, and that is if any of you can just give an overall explanation for the difference between physiologists versus physical therapy versus osteopathy and how they all relate or coordinate.
I can try. I speak to physiatrists or physicians that studied medicine and then did a 4-year training on physical medicine and rehabilitation. And like I explained a little bit on my slides, we learn about different impairments in different conditions, neurological, infectious, any type of condition, autoimmune. Anyway, we help patients cope with impairments and improve their quality of life. And then we work very closely together with physical therapists. Physical therapists, like it was mentioned earlier, are trained on helping the patients gain mobility, I would say, I think in a very simplified way. So they focus more on mobility and activity. The OTs, like it was mentioned earlier, are another group that works in activities of daily living, or basically showering, bathing, dressing, brushing teeth, how to make the patient more independent within the context of their impairments to be able to do those things. So, and then speech, language pathologists, they address swallowing difficulty, they address cognitive symptoms, and speech impairments. Now the physiologist, I'll let Dr. Friedman explain.
Yeah. Physiology is essentially the study of body systems or body organs, so that let me back up and say that there are two kinds of medical schools. There's allopathic and osteopathic. An allopathic medical school, where I taught for 34 years, Our approach is to build knowledge based upon the organ systems, so that we start with the cell and cells and how cells work, and we build them into tissues such as the nervous system, the digestive system, the nervous system, etc. So the physiologist studies at the cellular or organ level and tries to learn how those particular pieces work. And then in medical school, after allopathic medical school, after you study those organ systems, then you try to combine them or show the control mechanisms that put those organ systems together so that we can function as a total organism or a whole body. I have not taught in osteopathic medical schools, even though I now have a title in one. But the approach of the osteopathic schools is to treat the body more as a whole. So I suspect that in their coursework, there would be less emphasis on the organ or organ systems, but rather on the entire body. So that rather than focus on an abnormality in a particular organ, they would work from the body as a whole down to pinpointing the abnormality. But in pinpointing the abnormality, their approach would be the consequences of that abnormality on the entire body. Whereas in the allopathic school, it would be the abnormality in the organ system, and oh, what consequences will that have on the entire body?
Great.
Can I just say one quick thing about OT and PT? Often they come together tag teamed for a referral, OT, PT, do assessment and treat. And OT is from a public health. Our background is public health, and we have a view of bringing the person back to the meaningful tasks after injury, illness, disability has occurred. And we use multiple frames of references that will look at the nervous system and all of the pieces all of the body pieces of the body of the individual. PTs come from more of a medical model background. And so they are looking at the nuts and the bolts, how the body is working and what the physics and the structures of the body, the muscles are doing to the bone. And that piece of it, I mean, I think we really work well together, and often we'll have goals that resemble each other, but OTs will come at it from a kind of a roundabout way and looking at how the nervous system is working, and is the light too bright, is the sound too stimulating, so those are the pieces that we are looking at that make the activity difficult. But a person that has a PT view is going to come and look at it as a biomechanical, and that's why PTs really do a good job looking at heart rate monitoring and teaching, kind of because it's very structured. But there's no reason why an OT cannot become knowledgeable of that stuff too. So I think if you are looking for an OT or PT, don't be scared of one or the other and say it has to be this particular one. I think that if you find somebody and say, you know what, but it's a PT and I'm really having a lot of sensory issues, they can still help, but OTs probably have come to that more naturally, just in their background and in their training.
Great explanation, thanks. And thank you all three of you for such wonderful presentations, for your advocacy and for helping this population and moving the ball forward. So I think we're finally come to the end, but like I said before, all speakers have agreed to address unanswered questions, and we'll post those as soon as we can. And once again, this recording of this session will be posted on the Mass ME CFS YouTube channel, in addition to the slides being posted on the massmecfs.org website. Thank you all so much for coming. Our next Sunday conversation is February 20th, every third Sunday of the month at 4 p.m. Eastern Time. The topic is on applying for Social Security disability, and the presenters are two Mass ME board members with expertise in the subject. Ken Casanova, who leads the patient services team and has guided many, many patients through this process, and Rob Beluso, a board member and disability attorney. The presentation will focus on ME CFS applications, but will also review the Social Security rulings for fibromyalgia and long COVID. Finally, if you have found this program worthwhile, there are a few ways you can help. You may make a donation of any size to help support this series. You can donate online or at massmecfs.org/donate. On the same page, you can sign up for our newsletter. And if you donate $25 or more and check the become a member option, that will establish or renew your membership, and you'll be invited to our members only programs. If you have ideas for future programs or speakers, or if you would like to join the Sunday Conversations team, please email events@massmecfs.org. Sunday Conversations is not intended to be a series of research presentations, but rather programs that will provide a variety of practical information so that patients can use. So thank you so much again, and we wish you the best in the coming months.